Good afternoon and namaste. I'm Dr. Milan Adhikari, currently working as a lecturer in the Department of Pathology at Nepalganj Medical College Teaching Hospital, Kolhapur. And I welcome you all to yet another session of CE review series. Today, we are going to discuss in brief about the questions that were asked in the past CE examination under the pathology section. So let's begin with the first question. And the first question is Rouleaux formation with elevated serum level is seen in the options where lateral CV syndrome, multiple myeloma, aplastic anemia, and immune thrombocytopenic purpura. So before moving into the options, let's first know what a Rouleaux actually means. A Rouleaux is nothing but the RBC finding that we see in a peripheral smear wherein the red cells are clumped to one another and they form a clump. That clump resembles the stack of coin. The red cells are sticky to one another, and these red cells have stick to one another, forming a clump, and that in the blood. These serum proteins, when increased in the blood, the ground substance of the blood, when the serum protein in the blood is increased, then the RBCs get sticky to one another and thus will lead to the formation of a Rouleaux. These serum proteins, particularly fibrinogen and globulin level increase, will lead to the Rouleaux formation. So, any condition wherein we can get increased protein in the blood will lead to the formation of Rouleaux, particularly hyperfibrinogenemia, macroglobulinemia, some infections, multiple myeloma, other cancers, inflammatory and connective tissue disorders, diabetes mellitus. These are the various conditions wherein we get a Rouleaux in the peripheral smear. Multiple myeloma is a clonal proliferation of neoplastic plasma cells. It is a B cell neoplasm wherein the normal hematopoietic elements are replaced by the proliferation of huge number of neoplastic plasma cells. We all know the function of plasma cell is to secrete immunoglobulins, and these huge number of plasma cells will definitely secrete a large quantity of immunoglobulins. These immunoglobulin proteins, which when released in the serum, will lead to the formation of a Rouleaux. And if we talk about the clinical manifestations of multiple myeloma, the clinical major manifestations of multiple myeloma can be summarized by an acronym CRAB, wherein C stands for increase in calcium, R for renal impairment, A for anemia, and B for the bony lesions. The bony lesions in multiple myeloma basically are osteolytic type. Osteolytic bony lesions lead to the release of calcium from the bone matrix into the blood. As the lesions in the blood increase, the calcium in the blood will also automatically increase, leading to hypercalcemia. These calcium, when moved to the filtration pore of the kidneys, this will get collected there and obstruct the filtration pore of the kidneys, thereby causing renal impairment along with benzoin proteinuria. There will be anemia because the normal hematopoietic element of the bone marrow is replaced by neoplastic plasma cells. So, hemoglobin cannot get synthesized, RBCs cannot get synthesized, and will lead to anemia. Therefore, our question, moving back to it, the Rouleaux formation with elevated calcium is seen in multiple myeloma. Now, moving on to the second question, in which of the following conditions Starry Sky pattern is seen on microscopy? CML, standing for chronic myeloid leukemia, multiple myeloma, Burkitt's lymphoma, and follicular cell carcinoma. This is a pretty straightforward question. First, we should know what a Starry Sky pattern is. The Starry Sky pattern imparts to the morphological finding in a light microscopy, wherein the bluish dark looking cells are the neoplastic cells, and interspersed within these dark looking cells are these cells, larger cells with clear cytoplasm, larger vacuolated cells with clear cytoplasm. These are macrophages. And if we look into these macrophages, what we can see are the tiny phagocytosed debris within the cytoplasm. Under the background of these neoplastic dark cells, these interspersed macrophages or the tingible body macrophages impart the starry sky pattern, stars in the dark sky pattern, and this is very pathognomic of Burkitt's lymphoma. So Burkitt's lymphoma, it is a subset of aggressive B-cell neoplasms, and it is divided into three subtypes. Endemic type of Burkitt lymphoma, it is almost always invariably associated with Epstein-Barr virus infections. The other sporadic and the immunodeficient type might be associated with Epstein-Barr virus infection or might not be associated with Epstein-Barr virus infection as well. The immunodeficiency related type at times 30 to 40% are associated with HIV infection. This tumor, as I've already said, is a tumor, high-grade tumor. It has a high mitotic index, contains numerous apoptotic cells, and these apoptotic debris are phagocytosed by macrophages. These macrophages impart a starry sky pattern when observed under light microscopy. So when you talk about Burkitt's lymphoma, it has a characteristic 8-14 translocation between the CMYC and the IGH gene. So if you go to back to the question, which of the following conditions shows Starry Sky pattern? Our answer will be Burkitt's lymphoma. Which of the following micronutrient is accumulated? A question. The options being zinc, iron, copper, and magnesium. The correct option is the copper. Talking about Wilson's disease, it is an autosomal recessive disease which is caused by the mutation in the ATP7B gene. What does this mutation do? This mutation results in the impaired copper excretion in the bile, so that it leads to the failure of incorporation of this copper into the ceruloplasmin. Ceruloplasmin secretion will be very less, and this free copper will lead to the accumulation of toxic level of copper in many tissues, including liver, brain, and the eyes. So the pathogenesis of Wilson's disease, there is deficiency of ATP7B gene, like I've already said. There will be decreased release of copper into the bile, which will lead to decreased formation of ceruloplasmin by incorporating this copper. So this free calcium will be accumulated inside the hepatocytes. It will cause hepatocyte injury, and it leads to the non-ceruloplasmin bound copper, that is free copper, to be spilled into the blood, and thereby from the blood it can reach to various organs like brain, eye, cornea, etc. Moving on to the next question, which of the following disorder is associated with deficiency of type 1 collagen? The options are osteogenesis imperfecta, achondroplasia, Alport syndrome, and Marfan syndrome. This is also a straightforward question. So before moving into the answers, we should know that collagen is the most common protein in the body, and it is forming the matrix in large number of tissues in our body. There are various types of collagen, many types of collagen, and among them, the commoner ones are the 5 types, type 1 to type 5 collagen. Type 1 collagens are most commonly found in bone, skin, dentin, cornea, blood vessels, fibrocartilage, and tendon. Type 2 collagen are found in cartilaginous tissues. Type 3 in the skins, ligaments, blood vessels. Type 4 form the basement membrane of various tissues, and type 5 we find in the blood vessel wall, synovium, cornea, tendon, lung, bone, cartilage, etc. So now, when deficient, type 1 collagen, when deficient, leads to a clinical condition that is known as osteogenesis imperfecta. Type 2 deficiency will lead to chondrodysplasia. Type 3 Ehlers-Danlos syndrome, and type 4 the Alport syndrome. So in our question, the deficiency of type 1 collagen, it is found in osteogenesis imperfecta. Osteogenesis imperfecta, it is also known as brittle bone disease, and it is the most common inherited disorder of the connective tissue, and it is caused by deficiency in type 1 collagen synthesis. Principally, osteogenesis imperfecta affects the bones, but it has also impact on other tissues wherein we can find type 1 collagen, like joints, eyes, ears, skin, and teeth. It is caused by the mutation in the genes that encode for type 1 collagen, namely alpha 1 and alpha 2 genes. The fundamental abnormality in osteogenesis imperfecta is very little bone. So this leads to extreme skin fragility. In addition to the bony changes, other findings that you can find in osteogenesis imperfecta are the blue sclera, hearing loss, dental imperfections. Now moving on to another question. The most common type of carcinoma in urinary bladder is, the options are squamous cell carcinoma, adenocarcinoma, transitional cell carcinoma, and inverted papilloma. So before going towards the answer, first of all, we should know what a carcinoma is. Carcinoma is a malignant neoplasm or a cancer that arises from epithelium of any organ, any site. Of the four options, inverted papilloma is ruled out because it is not cancerous, it is benign entity. So now we are remaining with the three options: squamous cell carcinoma, adenocarcinoma, and transitional cell carcinoma. Urinary bladder has the lining epithelium as transitional epithelium, and the majority of the bladder tumors, around 95% of the bladder malignancies, carcinomas that arise in the urinary bladder, are the transitional cell carcinoma. So urothelial carcinomas or the transitional cell carcinomas are the bulk of the carcinomas arising in the urinary bladder, which are followed by squamous and glandular neoplasm. Yes, there can be squamous cell carcinoma, there can be adenocarcinomas whenever there is metaplasia of the transitional epithelium, but 95% of the bladder tumors by origin are transitional cell carcinoma type. WHO classification of the tumors of the urinary bladder also suggests infiltrating urothelial carcinoma, also known as the transitional cell carcinoma, being the most common type of carcinoma ahead of adeno and squamous cell carcinoma. So the answer is pretty straightforward. The most common type of carcinoma in urinary bladder is transitional cell carcinoma. Next question. Alzheimer's disease is associated with Lewy bodies, Negri bodies, cowhide type A bodies, and accumulation of tau proteins. So briefly discussing about Alzheimer's disease, what we know about Alzheimer's disease is that it's most common cause of dementia in older adults, and it is increasing with the increasing incidence as a function of age. As the age increases, the incidence of the disease increases, and the disease, as progresses, it causes the deficiency in memory, the visuospatial orientation defects, defects in judgment and personality, along with language, which emerge over a course of about 5 to 10 years. And then the affected individuals become profoundly disabled, mute, and almost immobile. It is the accumulation of two proteins, A beta and tau proteins, in specific brain regions, which are likely as a result of either excessive production or the defective removal, which are involved in the pathogenesis of Alzheimer's disease. And the hallmarks, pathological hallmarks of Alzheimer's disease are the amyloid plaques and the neurofibrillary tangles. These amyloid plaques are formed as deposits of aggregated A beta peptides in the neuropil, whereas the neurofibrillary triangles are the aggregates of the microtubule binding tau protein, which develop intracellularly and then persist extracellularly after neuronal death. These both neurofibrillary triangles as well as the plaques contribute to the neuronal dysfunction in the Alzheimer's disease. So going back to the question, Alzheimer's disease is associated with accumulation of tau protein. Cowhide type A bodies, these are found in herpes infections, Negri bodies in rabies, and Lewy body in Parkinson's disease. Let's go to the next question. The most common site for metastasis of renal cell carcinoma is, the options are bones, liver, lungs, and the lymph nodes. Talking about the spread of RCC, WHO classification of tumors of the kidneys, what it says is RCC has the tendency to invade the renal vein. Therefore, while grossing a nephrectomy specimen for renal cell carcinoma, we have to take one very important landmark as a margin, that is the renal vein margin, because renal cell carcinoma has a tendency to invade the renal vein. From the renal vein, the extension of tumor is likely to reach the inferior vena cava and then the right side of heart. Therefore, the most common route being the hematogenous route. From the right heart, the most common site of distance mates would be lungs, and then will be followed by bone, liver, and brain. So, hematogenous route of the spread is the most common mode of transport of metastasis in renal cell carcinoma. Lymphatic spread can also occur when the tumor extends beyond the renal capsule. So the most common site for metastasis of renal cell carcinoma is lungs. Other options are also the sites wherein the renal cell carcinoma can metastasize, but the lungs being the most common one. Another question. A patient having intense itching and jaundice is found to be positive for antimicrobial antibodies. Antimicrobial antibodies. What is the most likely diagnosis? The options are primary biliary cholangitis, primary biliary cirrhosis, primary sclerosing cholangitis, and dermatomyositis. What is an antimicrobial antibody? Antimicrobial antibodies are the autoantibodies which are consisting of immunoglobulins that are formed against mitochondria, particularly those of the liver cells. So the antimicrobial antibodies are formed antibodies, autoantibodies formed within the body, which are primarily directed against the mitochondria, that too of the liver cells in most occasions. When we talk of primary biliary cholangitis, it is an autoimmune disease which is characterized by the inflammatory destruction of small and medium-sized intrahepatic bile ducts. So it results from a T-cell mediated attack on the small interlobular bile ducts. T-cell mediated attack on the small interlobular bile ducts. And this antimicrobial antibody in primary biliary cholangitis is directed against the E2 component of the pyruvate dehydrogenase complex, which is the most characteristic finding in primary biliary cholangitis. Other autoantibodies against nuclear proteins and centromeric proteins may also be present, but the pathognomic of primary biliary cholangitis is the positivity for antimicrobial antibodies. So the option A is the correct option in this question. Another question, in which of the following condition pathologic dystrophic calcification is seen? The options are fat necrosis, hyperparathyroidism, sarcoidosis, and multiple myeloma. Before going to the answer, what pathological calcification stands for is the abnormal deposition of calcium salts in the tissues with a smaller amount of iron, magnesium, and other salts. So there is abnormal tissue deposition of calcium, and this can be of two types: dystrophic calcification and the other type being the metastatic calcification. Dystrophic calcification, it occurs in a dying tissue or in the setting of tissue injury or in inflamed tissues, and it occurs on the background of normal serum calcium level. Serum calcium level is normal, there is tissue injury, tissue destruction, and there is the deposition of calcium, and these all occur in the absence of derangement of calcium metabolism. The calcium metabolism is okay, serum calcium is normal, and these occur in the inflamed, injured, or necrotic dying tissues. This is dystrophic calcification. So sites of dystrophic calcification, as I've already said, this occurs in the setting of necrosis, either a caseous necrosis, a fat necrosis, or liquefactive necrosis. This can occur in the background of a hematoma or thrombus, an infarct, or the heart valve in the setting of endocarditis. So if you look at this picture, this is a picture of aortic valve wherein we can see the narrowed lumen of the aortic valve with deposition of these calcium deposits forming masses in the valve cusp. These are occurring in the setting of endocarditis. So another type of calcium deposition is the metastatic calcification. Herein the calcium salts are deposited in normal tissues, not dead necrotic tissue, but the normal tissues. And it always occurs in the setting of hypercalcemia and the disturbed calcium metabolism. So if we tabulate the differences between these two, then dystrophic calcification occurs in the dead and degenerated tissue, whereas metastatic calcification occurs in the normal tissue. Calcium metabolism is normal in dystrophic calcification, whereas it is deranged in the metastatic calcification. It occurs and the serum calcium level is normal. It occurs almost always in the setting of hypercalcemia. It is generally irreversible because it occurs in dead tissue, whereas the metastatic calcification is reversal upon the correction of metabolic disorder. Necrosis, infarcts, thrombi, hematoma, and old scars are the sites wherein dystrophic calcification occur. Metastatic calcifications can occur in systemic diseases like hyperparathyroidism, bony destructive lesions like multiple myeloma, hypervitaminosis, etc. So moving back to the question, dystrophic calcification, pathological dystrophic calcification occurs in the setting of local tissue death or necrosis. So the option A, fat necrosis, is the correct option. Moving on towards the last question. What is the main cause of coagulation inside the venous system in the case of malignancy? The options are endothelial injury due to the blockade of blood vessels, due to the invasion of cancer cells to the vessel walls, or due to the release of procoagulants from the cancer cells. So hematological abnormalities in cancer can occur basically via two mechanisms. The first is the increase in risk for vessel thrombosis in malignancy. In any malignancy, there is increased risk for vessel thrombosis, and this is owing to the increase in the count of platelet thrombocytosis and the increased synthesis of coagulation factors, fibrinogen, factor 5, and factor 8. Also, it is due to the release of procoagulants from the cancer cells, example being acute myeloid leukemia, prostate cancers, adenocarcinoma of the gut. These all can risk the intravascular thrombosis in malignancies. The another mechanism by which intravascular coagulation can occur in malignancies is by disseminated intravascular coagulation. It is due to the excessive release of tissue thromboplastin from the cancer cells. Therefore, the coagulation system thus activates fibrin clots in the microcirculation and leads to DIC. So, in our option, all the four are correct options which can cause intravascular coagulation. But the main cause in the case of in the setting of malignancy is the release of procoagulants from the cancer cell. This ends my presentation. Thank you all.